two psychiatrists rapping about our lives and work.
This podcast is not intended to be medical advice. Any stories we use have been altered to protect identities and sensitive information.
This is intended for entertainment purposes only.
You know it!
Ow!
Welcome to the Good Shrinks podcast. Hey, C.
Hey, T.
What's going on tonight?
You know, not much over here. It's been a good weekend for me. I've had off, so I've just kind of enjoyed myself for once.
Nice. I just got off my shift. And for those of you who are just tuning in, we're psychiatrists that work in a pretty busy emergency room setting.
Very busy. Having kind of a weekend off and getting to spend a little time with family. As psychiatrists, I feel like we get asked every question under the sun. Everyone expects us to have an answer for everything going on in their lives. And, this kind of just happened this weekend. I was out eating, and my aunt has a boyfriend who's like a really nice guy. He used to be actually a police detective in New York. And so he's very cerebral. And out of nowhere, we're like eating dinner, eating this really good Italian food. And he's like, see, what causes a midlife crisis? And I just kind of looked at him and I was like, that's a deep question.
But pass the rolls, please.
Yes. And so I was thinking about it, and I kind of let him answer the question a little bit. He's like, I really think it was like an unfulfilled state that the person was in at an earlier age. They didn't really get to experience, and it comes out later. And I was, I kind of mentioned like how in midlife, right, we tend to have more resources, maybe access to more things, so we can engage in more activities. And there may be unfulfilled things that have happened in the past. You may have points of development where you haven't kind of reached maybe a level that you are expected or some goal that you haven't achieved. But I was like, this is such an elaborate question for dinner.
Can I just eat my chicken, please? Well, for me, it's like my husband is one of these guys who, you're standing in line at the grocery store, and by the time you get to check out, he knows about your children, where they went to school, what you had for dinner last night, what street you live. He's just one of those people that's just very easy to get rapport with. And inevitably, he will go and talk to somebody, and first thing he'll say is, and my wife is a psychiatrist. And then before you know it, he's giving out my number, and I'm getting these random calls from people, and they have every number of things going on in their lives, either with them personally or with family members or another person at the checkout line, that they have all these questions. And so, yeah, we do get a lot of questions thrown at us.
Yeah.
At random times.
Oh, and it can be, anybody, family, neighbors, and, you want to help them the best you can.
Right.
And, I kind of realized really early in residency when those questions first started happening, it is kind of like, from our standpoint, you almost have to set boundaries, right? You have to tell friends, like, I'm not your therapist.
Right.
Give them clues along the way, but it is sort of one of those things where it's like, it's a fine line, and you really should seek a professional, but not me personally.
Right. Let me give you the number to the mental health center.
But while I'm asking to you, I'll put you on the spot. Like, what do you think causes a midlife crisis?
You are putting me on the spot. Well, I can go back to Erickson's. As you were talking, I was thinking about the whole, what's the term? The hierarchy, like these stages of development that we go through as humans. And there is that part that's right there in the middle, midlife time frame. Is it generativity versus stagnation?
Stagnation, I believe, yeah. Because before that, right, in young adulthood, it's like intimacy versus isolation. So it's like more about forming connections and love interest and romantic relationships. And I do think kind of more in midlife, mid-40s and beyond, it's more about...
Are you reaching the goals that you want, or are you sort of stagnating and not fulfilling
like
things?
Productivity in that way. Maybe in some ways, individuals that didn't have a lot of love experiences when they're younger, they kind of maybe draw back to that, right? Because as resources increase, you can buy the Corvette. You can get if you're really lucky, you get that Ferrari. You know what I mean? And,
right.
And then everyone can judge you.
And then they can call you about it.
Yeah, and they can call and ask about it. But no, so it's just kind of interesting, I think, from our standpoint. It's like, we're kind of like the go-to for those sort of things.
And, you do sort of have a responsibility to help people get to where they need to go. But I mean, it is difficult or impossible to take on everybody's, questions and what they need from you. You do have to set those boundaries.
Yeah. And, I think in some ways, talking about meeting people's needs, maybe expectations, I think like today a good topic would be talking about something I think everyone that's ever worked in an emergency situation of any kind knows.
Any kind.
The word malingering.
That is a big word. And it has to do with people coming in and wanting sort of manufacturing or making up symptoms in order to get some kind of secondary gain. And that could be food, shelter, warmth. It's cold outside, and so people come in with any number of stories that they make up in order to get those goals.
Yeah, to try and get those needs met. And I think, for us as psychiatrists, it's kind of determining like, at what point is the person seeking mental health needs and how much is it more of a social situation? And I think that can really vary. And something that's important is kind of, documentation, kind of seeing patterns of behaviors. Something interesting I think people may find is, they probably think like we work in an emergency room setting, like you see new people all the time. But T, that's not quite the case.
Right. And there are people that will come in and ask who is on shift before they even sign in. And if they find out, we had a colleague once that was just no nonsense with these folks. And so they would come in and say, is this doctor working today? And if the doctor was working, they'd say, nope, I'm not checking in. And they'd walk out. And so we should all try to be like that particular physician in terms of being very matter of fact. Now, the tricky part is that sometimes people who malinger do have mental illness. So it's kind of a fine line of knowing, is this flare up something that is actually legitimate mental illness that we need to address? Or is this somebody that really is just trying to get someplace warm for the night?
Yes.
And we do sometimes keep people that we're not sure. We might keep them overnight and then it'll become more clear. Because a lot of these people even confess as soon as they get admitted, oh man, I just made that up. I just said that because it's cold outside and I want something to eat.
And that's kind of the point of the documentation, right? We kind of document that. Like this person there's something like we kind of a joke about a little bit. And oftentimes people say, oh, they need a therapeutic sandwich, right? Like once they have, get something to eat, right? Or something to drink. And, they get that need met, then they don't really need anything after that. And I think to kind of maybe more specify is, from our standpoint, there's individuals that come into the hospital or to an emergency room setting and they express having thoughts of harm to themselves, like suicidal ideation. And that's something that we always take very, very seriously.
Very serious.
And so it's not something that malingering is a diagnosis of exclusion. A lot of patients that we see that we kind of know on a first name basis, like you kind of know who they are. I mean, you look at the records, and to give an example, sort of what do you do with someone this is their fourth emergency room evaluation of the day. They did not express thoughts of harm during the other three. And then they come to you and it's cold outside and they tell nursing staff they're here for a sandwich. And then they express to you, oh, by the way, I might have thoughts of hurting myself. And like, what do you do with that, right? The humanistic side is kind of like you always want to do what you can to help people. You always
do. And I wanted to say that it's just not that we are trying to turn everybody away. But there are people with legitimate, we only have so many beds. We only have so much space. We have to really prioritize those beds and that space for people that we can actually make a difference and help. And so when people come in and they're not serious about mental health concerns, they are just wanting to get their social needs met. Definitely you have empathy for that. And there are social workers. We try to get people connected. But when you're making up stories that you have just admitted that they are not true, then, you have to kind of put your foot down and say, there is nothing that we can help you with in this particular situation. And that's always hard. It's always difficult to get into those kind of conversations with people, but you have to do it because, first of all, they should be using all the time that they spend to get into a hospital setting. They could be using that for the good. To get resources in other ways, or to work on job skills, or to reach out to that family member that they're in conflict with, and try to get things resolved. Just coming and spending the night in the emergency room doesn't solve any of their problems. They're still there, so they're likely to come back tomorrow when they don't have any other option. So in some ways, you're actually hopefully giving them an incentive to say, no, you have been here before, we have treated you, but now it's time for you to figure out how to do this on your own. So sometimes it's those kind of conversations and confrontations.
Yeah, just to give
what
a little...
What do you think?
Yeah, I mean, kind of to give a little bit more clarity, because I don't want people to think we're just like turning everyone away, which is not the case. It's more so like examples of someone's been hospitalized twice in a row, inpatient, back to back. And they come back the day they're discharged for the third time, and they say the same thing. And you're right, there usually is an underlying need that's not being met. Like if the person is homeless or is having, like you said, conflict with a family member, and they're not really willing to address that, and they choose to avoid that family member, and they don't really have any other support. So it is sort of us, trying to read between the lines. And, it is becomes a little bit of an enabling behavior, right? So sometimes it's hard. It's like you want to help, and then also you don't want to enable, and it's such a fine line. And I think you bring up a good point. Some psychiatrists, their approach is much more like matter of fact. Sometimes people are a little bit more lenient, and I don't think there's like necessarily a right or wrong on that. I think we need a little bit of both, right?
It's the case in the moment. What is going on at the time? What is going to be most beneficial for the patient? There are certainly times when you don't know if they're making it up or not. I think, what is going to help me go to sleep at night and feel at peace? Is this somebody that I'm going to be up worrying about if I let them go? Well, then I'm going to admit that person, and I'm going to try to sort out those questions and document what my concerns are. And so that when the team picks it up tomorrow, they can kind of look and see what I was thinking. And then, documentation is so important, not just at our facility, but other facilities. Even though we complained about our EMR, our medical record system, that's a whole episode. We are able to see a few more facilities, even out of state. We can see where people have been seen. So if we see things that we can just give feedback to the patient, hey, look, this is what the other doctors are saying when they've seen you, and this is what we said when we saw you earlier this afternoon. What has changed? What are you working on? What are you doing? I saw a patient, I was asking him, he had just been discharged from the hospital like maybe a little over a week ago, got sent to a facility, and then had something happen, and he was discharged from that facility, and then showed right back up at our emergency room and wanted us to just admit him back to the hospital. And we were like, but what is new? What has changed? What can we do? Have you talked to your outpatient team? And he said, I don't go to clinics. I go to hospitals. Like the whole concept of outpatient care, continuity of care, being with a team that's going to encourage you and support you and monitor you over time. Let's make sure we got the right diagnosis. Let's make sure these medicines are working. None of that was really processing with him. He was just like, nope, I go to the hospital when something's wrong or something I need. And so it's really education too with people. We're trying to educate them. There's only limited things that the emergency room can do. You're going to have access to more resources if you follow up outpatient with teams that have social workers and nurses and clinicians and psychiatrists and therapists. We don't have all that in the emergency room. And I know we're a familiar face a lot of times, like you were saying. We see people over and over again that get used to us. Maybe we're the only place where they can come and get a kind word. You don't know. And so we're going to offer that kind word, but we're also going to offer some hard love too. Like you got to do this on your own too, to some degree. Yeah. And don't depend on the hospital to get your needs met. This is an opportunity for you to step up and take care of yourself.
T, for you, we do have those tough cases of, repeat offenders or individuals who do often get hospitalized and kind of fall off their medications afterwards. Another big thing is substance abuse, right? Maybe get re-involved with substances and they decompensate and they just never have really sought outpatient care. And you see this cycle going on for years. Not so much about the patient, but like, how do you feel going into the room with them when they've kind of developed almost like this helplessness,
I just cry.
Yeah. That's all we do, people. We just cry.
I just cry. I just fold up into a little ball and like, not again. No.
Well, it is a feeling of helplessness, right?
Sometimes.
Mm-hmm.
But then I remember who I am.
Yeah.
I remember my role.
So he goes, I'm a badass bitch, and I'm coming in the room, so y'all better watch out.
I just remember that, I have to see people where they are, and I go with what they tell me. But then I'm also going to, if I have a record that has information that's relevant to what we're talking about, I'm going to bring that up. We're going to talk about all of these things. Now, it may still be that somebody was a malingerer, but is legitimately in crisis now. I mean, you have to look at each case. This is the other danger, is that you see somebody's name and you automatically make a judgment about why they're there. You really do need to see everybody in the moment, because I have certainly admitted people that had this history, but then today there was a crisis and there was something I legitimately thought we could do to help. So it's not just seeing the name and seeing that diagnosis and just deciding that there's nothing you can do. You really should look at it case by case. But when substances get involved, it's hard for lots of reasons. One is they're in an altered state of mind. So you can't really, you're not going to get the best evaluation of how they are mentally in those situations. So sometimes you have to keep them overnight just to let those substances pass, and then you can kind of talk about what's going on. Other times, because we're fortunate that we have some substance abuse facilities that are also 24 hours in our environment, we can send people straight over there as long as they're not, dangerous or agitated or paranoid. So it depends. I'd say case by case is the way I look at it. I try to not go in with preconceived notions. It's hard as a human to not be biased.
Yeah.
But I try, I try to really see each case as a new case.
I definitely think that the critical thinking aspect of things is a big part of what we do. And you're right, staying unbiased. To give an example, I had a case of someone that had been labeled malingering, kind of shown up over the past 6 months and was constantly presenting to emergency departments. And once he kind of got that label, it was kind of automatic discharges, right?
Yeah.
And I was like, well, he's only been doing this for a few months. So I called an ex-girlfriend of his who happened to be a mental health worker, actually. And I did not see anywhere in the documentation that she'd been contacted. She was like, no, this is a stark change of how he was from a year ago. So I'm like, he actually may have some underlying psychosis. He may have some antisocial traits that makes him hard to deal with. But I'm like, there's really something going on here. And it kind of took that extra step, right? Because once you get that label, it can easily be, oh, this person is just doing this for this reason. And so you're right, it's hard to maintain that neutrality at times, because there is a lot of substance abuse filtered in, and I feel personality component in a lot of the individuals. That can be, maybe we can talk a little bit about that, about how that's hard, I do think, kind of like you were mentioning, the substance abuse part is hard, because when someone goes back and it's a cycle. They maintain some sobriety after being in the hospital. People, places, and things. They interact with the same people when they leave, because they have to go back to kind of where they were, what they know, and quickly relapse, and then keep presenting for very similar presentations. And it can be hard to kind of figure out what to do for them next. Because again, you don't want to enable, you can kind of just come here and detox off drugs, unless you're serious about wanting to stop. So that can be kind of tough. Especially
since those people might actually feel like they are serious in the moment and are very genuine that they want to. And then they come back a month later and that's part of why they're depressed, is that they had all these dreams for themselves and then it didn't work out, or some setback happened, or some stressor. The other thing about substance abuse that makes it difficult is that it can alter your mood.
Yeah.
And it can induce psychotic symptoms.
Oh, yes.
You can't tell the difference between somebody who's schizophrenic and somebody who is psychotic from methamphetamines. And they are very scary. And so, again, when there are things like that, yes, I don't necessarily think that's malingering. I guess there could be some malingering aspect. But the actual symptoms that you're seeing, those are true psychotic symptoms. But fortunately, they should pass.
Yes.
Once they have a little bit of time to sober up.
Yeah, they should reconstitute after a period of time. And those kind of cases, I think we're pretty good at we hold them and kind of ensure that they kind of stabilize. I think substance abuse, we can do definitely multiple episodes on, because that's a big part of what we do.
Bipolar, right. Manic, very manic.
They become very manic and very disorganized. Thinking about psychosis, like let's say someone is malingering for psychosis, right? It's more so they'll tell you they're hearing voices. They are as clear as day, like talking to you and me, like we're talking right now.
Like, what are some signs of psychosis that we might see in an emergency room that makes us think that it's true psychosis? What are some symptoms that you see?
Yeah, so for me, psychosis, there's positive symptoms, which are more symptoms that are like auditory hallucinations, paranoia, delusions. Those are more so the positive symptoms of psychosis. And then individuals may have negative symptoms where they have like a very flat affect. They're very withdrawn. They don't really make any eye contact. I think individuals that have more of like a substance-induced psychosis, they show more of the positive symptoms, right? Versus someone who has a primary thought disorder, then they kind of have more of a mixture of both. But I would say someone like, let's say, malingering for those symptoms, right? I had one instance, this guy said he was hearing voices, and I was like, well, tell me a little bit about them. And he said, the voices told me I need to get some rest.
And a peanut butter and jelly sandwich, please.
And make it snappy.
Why are you still standing here?
I already told you what I need.
That's right.
So those are like, okay, yeah, there's more of a personality component to those sort of things. And
if a person is hearing voices, generally, if they're actually hearing voices that are troubling them, you can tell when you're talking to them because they're not just looking at you. They're looking around the room at whatever just talked to them, or they're looking up, they're hypervigilant. They're looking all around them like somebody's about to come up behind them, and they're respond. That's what we call responding to internal stimuli. There's something going on inside that they're responding to, and you can see that, and you're like, what did you just hear? Yeah. And they'll tell you if they can. They are often disorganized, like they cannot get their sentences together or their thoughts together enough to even tell you what is happening, or their words are kind of slapped together. There's like words that don't make sense, like they say hey instead of yes, or like they use their associations to the words are not correct. They're just very clear things that we see with people who are psychotic. So if you just come in and say, I'm hearing voices, and then we ask you about the voices and you're able to just clearly tell us, then, it's just one point on the data graph. It's not like that is completely canceling out that you have them, but no, it's less likely. And other things like the duration of the symptoms, like we're looking at, I will speak for myself. I don't generally diagnose people with anything in the emergency room because I'm just seeing them at that one point in time. But I can gather the list of symptoms that they're describing and then kind of decide where do they meet. Do they meet criteria for any particular thing? Or is this more that we need to monitor over time to get a diagnosis? So yeah, gathering symptoms, you're looking for psychotic symptoms. You're going to look at the physical attributes too, because when we do a mental status exam, we're looking at not just what they're telling us, but their behavior, kind of how they're moving around, how they're dressed. Sometimes gives you a clue. Like if they're manic, they might have on 5 different pairs of clothes.
Oh yeah,
3 layers of makeup, and so you do get some extra information in the mental status exam.
I agree. I think your kind of appearance is a lot of it. If someone's very disheveled, malodorous, you just know immediately they're not caring for themselves.
Right.
Or if they're manic, they may show up with like multicolor everything, a lot of
3 wigs,
jewelry, 3 wigs, like they're going out for a night on the town, like neon everything. Like it's interesting when that happens. And, you're right. The longer you're in the field, the more you almost can pick up even within a minute of being in the room of what may be going on.
Right.
But saying that, I do think with like malingering, a big thing is collateral. Getting information from family members. And sometimes that's something that takes a lot of effort, but it's really kind of where you'll get most of the information. Because you have family members that will say, oh, this person's been doing this for years. They go to the hospital when they need a night, or, they're using drugs and they just don't want to stop. And really, at that point, they've exhausted all of their they've basically burned their bridges. And so, you get a feel for, well, they've reached that point and they're at a very low, and so they're kind of using us as a last resort in those situations. We want to help them the best we can. Like if you want substance abuse treatment or if you want to get better from that standpoint, we want 1,000%, go bend over backwards to make sure that happens. But it is tough when we get those cases where, they're not ready to stop. And so, it's kind of like some psychiatrists will say, hey, you're back on the street. And others will say, well, I'll give you a little bit of time. And it can be a tough situation for us, it really can.
Yeah. But we just do the best we can. These are not easy cases that we have. That's why they're in emergency rooms.
Yeah.
These are people that are in crisis or the family doesn't know what else to do with them. They really just we've had people with diagnoses that we literally cannot treat, like people who have nonverbal disorders, developmental disorders, or intellectual impairment. We do not have programming for a lot of those cases. We often have to tell families who are really struggling with their behaviorally dysregulated people that we don't have anything for them. And it's very hard to do.
What do you think, and this is kind of a hard question to answer, but what do you think has led to malingering?
See.
I'll throw you all the easy stuff tonight, T. She's the one that had a shift.
I'm tired.
She had a shift too, and I'm over here like, I'll throw her all the hard questions. But like, what do you think has contributed to malingering in kind of this day and age?
So many things, see. And maybe it's that they made some decisions early on about their education, their career path, substances, maybe legal issues happened, and they have fewer opportunities now as they've gotten older. And so they don't have very much purpose. They don't have very much direction in their lives. And all they know is just day to day on the streets, like how to survive. And one of the things maybe they've picked up along the way is, hey, if you say this and go to emergency room, they'll keep you for a day or two. That I have heard that just in passing by and listening to conversations with people in the hallway. They share stories. They share things because it is about survival out there. So I think that's one thing. What do you think?
Yeah, you just sort of sparked a memory when you're saying this. One of the psychiatrists we work with who's been there a very long time, like kind of probably close to retirement, but you never know because she's like a powerhouse. She, really, the people who do sort of malinger are really exhausting that resource. It's like they're really just trying to live. They're kind of like you said, using whatever resource is available to them to just make it by.
One more day.
Yeah, and I agree. I mean, some of them do have like legal history, felonies. I mean, they
can't get it. Yeah,
or it's substance abuse preventing them from maintaining consistent employment. I mean, or it could be underlying mental illness. You've been bringing up like developmental disorders. I think it's underdiagnosed. I think a lot of times people that are diagnosed malingering, they actually probably have a lower than average IQ and have trouble sort of navigating things. And, that kind of goes into hopefully another topic we talk about soon is like deinstitutionalization, and whether or not that's right or wrong is like an ethical question. But it kind of has created a community of homelessness, right? And I think it's a big issue in a lot of cities, and kind of managing that is really difficult, and kind of right now we're kind of the catch-all, right?
Exactly. And I think that homelessness, period, so many people become homeless for lots of different reasons. And I think mental health is probably a big percentage of that. Once you are on the streets and you don't have a place to go, a place to wash yourself, a place to, eat and call your own, you are pretty much at the mercy of whatever is happening out there. So there's lots of crime. There's just hopelessness. There's, what am I doing here? What's my purpose? What am I supposed to do? Part of that, I think there's some people that they are happy to be homeless. They've been homeless for 50 years and they're making it out there somehow. And so, those are not the ones literally who come to us.
It is a lifestyle.
It is a lifestyle.
There's like kind of an underground community of it in a sense. It's interesting.
And they're free. Like they feel they don't have they're not paying taxes. They're not out there worrying about getting up and punching the time clock.
And, you kind of brought that up, like with malingering or individuals that do that. Like I do notice a trend that some of maybe the higher functioning malingerers, like they do a lot of like traveling. Like they get on a Greyhound bus. Once they've exhausted kind of resources in one area, they're on to the next. I mean, it's like they're all over the country.
I've had many people that come in that specifically just ask for a bus ticket to another town, because they've heard that sometimes you can get a bus ticket. Yeah, they're on their way. But then like a month later, they're back.
Yeah, they're like, it was better here. We're coming back.
Oh, man.
It's kind of funny. But
I mean, we have a pretty colorful job. We see a lot of interesting people. And yeah, deinstitutionalization, I guess we will get into it at some point. But one of the things, again, whether you're for it or against it, the state hospitals did have, one of the things going for them was that they sort of gave people a purpose. Like they had chores. They had things that they had to do on the farm, you know, where a lot of these, some of the mental health centers are on farms, like huge plots of land where people could garden and harvest vegetables. And then there was other people that would cook the vegetables. And then they sort of opened up a whole restaurant. Mm-hmm. And these people had something to do. And they were there getting counseling and therapy and treatment, but they also had responsibilities. Mm-hmm. And I feel like that is something that is missing out there. These people who are homeless or who are mentally ill and not able to really maintain in society, they're not getting that structure, the responsibility, the accountability, you know, for doing things and the encouragement to go make something of your life. Well, what are you going to make of your life if you're just, you know, this is what I hear from people. If you're just homeless and on the street, what do I have to live for? Mm-hmm. You know, and so part of what we do is try to help people see what else there could be for them. We do a lot in the emergency room.
Yeah, we
a lot of magic is happening there.
So much. Speaking of the magic, you know, I was sort of, I was thinking, because it is a magical place.
It is. The guy was talking about voodoo today.
Oh, okay.
Yeah.
You know, for just thinking of like responses to things. So like, let's say, you know, you made the decision, like this person's malingering, right? And you have to go kind of inform the person. They're not going to get what they want. Yeah. Right? So the responses by the patient can be kind of different. I have some perspectives of that, but like I want to hear from you too. Like, do you think...
It varies.
Yeah.
There's the jig is up. Like they know. Oh, like, okay, you got me.
Yeah,
you got me. Okay, all right.
Like, okay, cool.
Then there's the ones that get very defensive and angry, and they're going to show you why they need to be, you know. Mm-hmm. So then there's those. I had one guy, as I'm talking, and this was a telepsych evaluation, so I actually could see them as we were talking, not in the room with me. He was in a medical emergency room. Clear. I mean, it is a diagnosis of exclusion, but this man had it written as that is his diagnosis, and he just reams of papers of, you know, talking about how he confessed this is what he does to get into the hospital. Mm-hmm. So I shared that with him. I was like, you know, it looks like when you come to hospital settings, you say whatever it takes to get into the emergency room. And this is quotation marks from what you told the team. Well, I don't care what I said. This is what's going to happen and blah, blah, blah. And I was like, but sir, how is the hospital going to help you from the 10 dozen times that you've been to the hospital? What is it extra that we're going to do this time? Or what is it going to be different this time? It doesn't matter. I want to be in the hospital. So I said no. Mm-hmm. I told the team, the emergency room team, what I was doing. And as I'm getting ready to turn off the monitor, he picks up a cord from inside the emergency room and just sort of loosely wraps it around his neck.
Oh, yeah.
And so I called the emergency room team and say, look, this guy's in here doing this. And they get in there. I mean, it is loose. He's like, do you see what I'm doing? Do you see? Do you see? And I was like, I'm looking right at you. I can see what you're doing. He was like, well, you're not going to send me out of here. And I was like, there are going to be some people coming to talk to you in just a minute. And so loose as can be. And as soon as the people came in the room, he just tightened it. Yeah. But still, like, I mean, they were right there and they took it right off of him. But so some people will do whatever it takes to try to get into a hospital. And then you try to work with them once they get in the hospital and they don't have anything. Yeah. They're not interested in changing anything.
And that's the hard part.
Or addressing anything. So even if you put them in the hospital, you're still not getting any kind of benefit for them because they're not ready to face it.
Change. And that can be the hard part, kind of reading the notes once they're in the hospital. It's like sometimes, this is just examples, it'll also be like, you know, inappropriate with female staff or not going to groups or very dismissive.
Med seeking.
Yeah, very much like seeking only like the controlled substances. I mean, there's a very similar pattern that we kind of see for that. And the hospital is honestly, it's kind of a dangerous place. This was not anytime recent. This was back in residency. There was someone that would escalate like that, and so he would come in after using substances after like 1 or 2 weeks after he kind of went through all of his funds, and he would escalate if you told him no. So he would kind of really, cut himself deeply in the arm, do whatever he would have to do to get admitted, and he was doing that for years, and he ended up contracting a hospital-acquired pneumonia like while I was still in residency, and he passed away at a relatively young age. So I mean, being in the hospital is not completely benign, and there's a lot of resistant bugs in there, and bacteria.
Dang, man.
And I mean, you just not saying his other lifestyle choices may not have been great either, right? But like it will catch up to a certain point. So yeah, it's tough. That's kind of stuff can be kind of tough to watch. I don't want to be too depressing about that, but
wow,
it is.
That's yeah.
Yeah, and I think
watch out for what you ask for.
Yeah.
You might get it.
Exactly. But I think it's one part of our job that we deal with really on a daily basis to some degree. And I think really a lot of emergency services, it can really exhaust the staff. And
I think so. I mean, I think it affects our morale. If we're seeing, like, what are we doing?
Yeah.
Are we really helping people if the same people are coming in and saying the same things? But then you'll get those people who this is their first time in the emergency room and they're scared and they don't really want to be there and they don't know what's going to what to expect, and you're able to educate them and encourage them and talk to the family, and they're like, I'm so glad I came in today. So for every malingerer who takes up a lot of our emotional reserve, there are those people who really, not that the malingerers don't need help too, but it's good to be able to actually have a benefit for somebody and, not feel like you're being taken advantage of.
Yeah, and I think that kind of balances out our job.
It fills up the tank a little bit so then you can go out and fight another day.
Exactly. Maybe next time at work, I'll be like, I'm not here to work, I'm just malingering.
But what would be your secondary gain?
That's true. The snacks. The snacks are good. Well, if you like candy, they're really good. The Reese's peanut butter cups.
I mean, I am very glad that they gave us that little perk.
Yes, agreed. Well,
late night sessions.
All right, everyone.
Y'all take care.
Ow!
Have a good week.